I'm Dr. Raphael Stricker. The title of my talk is The Beer Protocol for Recurrent Pregnancy Failure, 15 Years of Beer Babies, from the Alan E. Beer Medical Center for Reproductive Immunology, Los Gatos, California. For those of you who knew Dr. Beer, he was a pioneer and an innovator up until his untimely death in 2006. One of the highlights of his practice was the annual picnic where Dr. Beer showcased the fruits of his labor, so to speak. And upon his untimely death in 2006, there was a memorial symposium presented at ASRI, which coincidentally that year was in Nashville, Tennessee. So my talk today will focus on recurrent pregnancy loss and recurrent implantation failure with the outline shown on this slide. First of all, the problem. As women get older, the miscarriage rate rises significantly, and by the time women reach the age of 45, about 3/4 will miscarry. Although IVF has been proposed as a way to address this problem, if you look at the success rate with IVF in older women, it's really not that impressive, with rates in the 20s to teens as women get around age 40. So what causes this problem? There are really two sides of the same coin with recurrent pregnancy loss and recurrent implantation failure. Both problems occur in similar age groups, similar histories of pregnancy failure, and similar immunological, metabolic, and coagulation abnormalities. And this classic slide showing the immune balance in pregnancy with Th1 versus Th2 type responses has been kind of a model for how to think about problems as women get older and problems with their immune system. The problem with that is that the immune system has become much more complicated over the years, and this slide gives you some idea of all the factors involved. I'm not going to have time to go through all of this, but obviously there are a number of factors that need to be addressed and that contribute to pregnancy failure. So the Beer protocol is a combination of therapeutic modalities designed to address immunological, metabolic, and coagulation abnormalities that contribute to recurrent pregnancy loss and recurrent implantation failure. And just to put this in perspective, this is the famous allegory of the blind men feeling the elephant, and in this case the blind men know it's an elephant, but they can only feel one thing at a time: the trunk, the tusk, the leg, the body, the tail. And it's important to consider all the parts of the elephant when you're designing a protocol to deal with recurrent pregnancy failure, and that is essentially what the Beer protocol does. So how do we assess these problems? Well, diagnostic testing has been developed. For immunological testing, the most significant abnormalities are shown on this slide. Low leukocyte antibody levels, high natural killer cell number and activity, low T regulatory cell numbers, high Th1, Th2 cytokine ratios, and then various autoantibodies that are associated with recurrent pregnancy failure. And this is based on a cohort of 1,414 patients with recurrent pregnancy loss and implantation failure that were screened at the Beer Clinic over the past 15 years. And most patients in this group actually had more than one abnormal test result. So for leukocyte antibody detection, this is a measure of maternal anti-lymphocyte antibodies to paternal HLA antigens. These are IgG antibodies detected against T cells and B cells, which are so-called blocking antibodies. They protect the fetus against the mother's immune system. And these antibodies are detected using flow cytometry, as shown on the right here. Natural killer cells in pregnancy, again, there's a balance between normal pregnancy with normal CD56 natural killer cells and normal natural killer cell activity versus high CD56 numbers and activity in pregnancy failure. The T regulatory cells, or Treg cells, are also significant in pregnancy loss. So looking at pregnancy success with low Tregs, it's only 44% versus 80% with Tregs greater than 0.7%. And this is from a study done by Dr. Winger a number of years ago. And then cytokine ratio, Th1, Th2 balance, is also important for pregnancy success, with the Th1, the cytokines associated with IVF failures, Th2 cytokines associated with normal pregnancies. In particular, tumor necrosis factor is the significant cytokine associated with pregnancy failure. Now, other factors in this equation, metabolic testing is important, and here we've seen thyroid abnormalities, low serotonin level, and insulin resistance. And then coagulation testing. Almost every patient with pregnancy failure has some thrombophilia gene mutation, and then also antiphospholipid antibodies may play a significant role in pregnancy loss. So thyroid disease and pregnancy failure, it's well known that the thyroid regulates both fertility and the pregnancy outcome, very important. Serotonin is a key signaling molecule in embryogenesis, and it's involved in placental nutrition, nutrient acquisition and metabolism, and also, interestingly, may decrease tumor necrosis factor levels, which I'll show you a little bit later. And insulin resistance, also significant. Women who have insulin resistance have 3 times the number of miscarriages compared to women who do not, as shown on this slide. And then gene mutations associated with inherited thrombophilia. These are the ones that we test for. The 2 MTHFR mutations, PAI1, factor 13, factor 5 Leiden, and prothrombin. We consider both homozygous and heterozygous mutations to be significant, according to the most recent literature showing that even heterozygous mutations play a role in pregnancy loss and failure. Antiphospholipid antibodies, we measure 3 classes of these antibodies, IgA, IgG, and IgM, and 6 types of antibody as shown here. It's known that antiphospholipid antibodies are associated with delayed formation of the syncytial trophoblast and resulting in pregnancy loss or implantation failure. And just to show you what this testing looks like, this is an old slide from Rosalind Franklin University showing a positive test for antiphospholipid antibodies. We consider any of these forms of antiphospholipid antibody to be a positive test to be significant. So, treatment. How do we treat these problems? So for the immunological problems, there are several modalities that have been useful. LIT, lymphocyte immune therapy, has been used for the leukocyte antibody and natural killer cell abnormalities, along with intravenous immune globulin and dexamethasone. And then for the high cytokine ratios, adalimumab, which is Humira, has also been useful to suppress those cytokines. So lymphocyte immune therapy, first of all, I have to say it's not approved by the FDA, so not available in the USA. It is a treatment that addresses the low leukocyte antibody level, and the form of treatment is very important. So the LIT has to be done with paternal lymphocytes injected intradermally into the potential, the prospective mother's arm. There are other ways to do this that don't really work as well, and I don't really have time to discuss that. The procedure itself is rather straightforward, and the results of the LIT in terms of leukocyte antibody detection, an example is shown on this slide. So you may have maternal serum prior to LIT with 1 to 5% antibodies with the normal range or desired range of greater than 50%. After one round of LIT, the level may go to 30 to 50%, so almost there, but not quite. After 2 rounds of LIT, generally you get levels of 89 to 99%, and that is optimal for pregnancy. Intravenous immune globulin, IVIG, has been around for decades. It has a number of effects on the immune system, as shown on this slide. I don't really have time to go through all the different mechanisms, but it's been a very useful treatment for the immune complications associated with pregnancy failure. There is controversy concerning IVIG in terms of failed IVIG trials versus successful IVIG trials, and Dr. Winger and I did a paper a few years ago looking at the difference between these studies. And just very briefly, in the failed IVIG trials, the patients were much younger, 31.9 years average. These studies excluded women with immunologic abnormalities, and the initial IVIG treatment was done following conception. And then IVIG administration was done at non-physiologic intervals, usually 1 to 2 weeks during pregnancy. In contrast to that, successful IVIG trials were in older patients, the average age 36.4 years. Women were included with immunologic abnormalities, which makes sense, that's the target population. And the initial IVIG treatment was done prior to conception. And IVIG administration was done at physiologic intervals during pregnancy every 3 to 4 weeks. So this controversy, you may see papers saying IVIG doesn't work, but just think of this contrast here. Dexamethasone, we use dexamethasone because it stabilizes the clotting system, suppresses natural killer cell function, increases T regulatory cells, and suppresses autoantibody production. So it's very useful in this situation. And the reason that we like dexamethasone as opposed to prednisone is that it has less side effects than prednisone in terms of fluid retention, hyperglycemia, and hypertension. Adalimumab, Humira, is a fully human anti-TNF monoclonal antibody, which has a high affinity for TNF and a long half-life of 12 to 14 days. So it can be dosed every 2 weeks. And can be dosed by the patient. Here's a picture of a happy patient giving herself an injection of Humira. I've never actually seen a patient smile doing this, but I guess in this situation, it works. And the safety of anti-TNF therapy has been a concern, but we use this treatment well before embryo transfer. This eliminates any possible fetal exposure to the drug, and a short treatment course, usually 1 month, avoids the risk of lymphoid malignancy that's been seen with chronic use of anti-TNF therapy. And then metabolic treatments for thyroid abnormalities, we use thyroid hormone plus or minus immunosuppressive therapy if there are autoantibodies to the thyroid. A low serotonin level, we use SSRIs to boost those levels. And then for insulin resistance, we use metformin. And just to go through that briefly, thyroid treatment is fairly straightforward. For the serotonin uptake inhibitors, interestingly, there is a meta-analysis that shows that they can decrease TNF levels, as shown on this slide. Not a big decrease, but significant. And that's in contrast to other antidepressants that have no effect on TNF levels. And then for the insulin resistance, metformin is the standard of care. And then for coagulation treatment, for the thrombophilia gene mutations, we use a backbone of baby aspirin, enoxaparin, and dexamethasone, with folic acid for patients with the MTHFR mutation who tend to underutilize folic acid. And then for antiphospholipid antibodies, we use the same backbone plus IVIG. And again, just to show you this, baby aspirin, enoxaparin, and dexamethasone as the backbone treatment for coagulation abnormalities. Heparin and Lofinox, interestingly, have effects on implantation, can improve implantation, as shown on this slide. And And then for folic acid, I should mention that the 5 milligram tablets are not available in the US. That's why the nurse is saying, shh, don't tell anyone. But we usually use about 4 milligrams as a supplement. And then progesterone is another hormonal treatment that's usually given by the OBGYN or RE. Progesterone may not help, but it can't hurt. So, what are the treatment results? Well, this is the overall population screened at the Beer Center over the past 15 years with 1,414 patients. The mean age at conception was 37.8 years, with the mean number of prior live births that was very low, 0.5, and mean number of pregnancy failures, about 4. Now, for women using their own eggs, we used a control group from the medical literature of women who were eligible for IVF, which basically is this entire group. And the success rate with IVF was 23%, going from the bottom of the slide to the top. With addition of baby aspirin and enoxaparin, that rate went to 28%, which was not significantly better. But in adding IVIG plus anticoagulation, the rate went to 64%. And when we add LIT plus IVIG plus anticoagulation, a 70% success rate, which was highly significant. Again, women using their own eggs, but with high cytokine levels. These were women eligible for adalimumab treatment. Again, the success rate improved, not quite as much as patients without these high cytokines, and I think the high cytokines do impair pregnancy success, but we still managed to get rates of 56% and 64%, which were significantly better than controls. Now, in women using donor eggs, the age at conception was significantly older, 43.6 years. Mean number of prior live births also very low, 0.5. And number of pregnancy failures, very high, 5.2 average. In women using donor eggs, here the control group, going from the bottom to the top, the success rate was 36%. Using baby aspirin and enoxaparin, that rate went to 57%, which is not quite significant. But using IVIG plus anticoagulation, the rate went to 69%, and adding LIT to the IVIG and anticoagulation, 76% success rate in these older women, and that was a highly significant improvement. And one interesting group is women going for second babies in the program, and we had a number of those with an average age of 37.6. The mean number of prior live births was 1.2, and the mean number of prior failures was 5.5. When we looked at this group, interestingly, again, the control group would be 23% success. Even with just baby aspirin and enoxaparin, the success rate went to 70% in these women. And then with IVIG, 74%, LIT plus IVIG plus anticoagulation, 86%. So this group did very well with second pregnancies, even with minimal treatment of their abnormalities. So in conclusion, recurrent pregnancy loss and recurrent implantation failure are significant problems in older women attempting pregnancy. The Beer protocol addresses immunological, metabolic, and coagulation abnormalities associated with RPL and RIF. Treatment of these abnormalities is associated with a significant increase in pregnancy success, and further studies are needed to evaluate the diverse components of the Beer protocol. And future directions, I want to mention that it would be nice if the FDA would approve LIT at some point. That would be very helpful. Also, if we could get insurance coverage for IVIG, which remains quite expensive, and improved immunotherapy for natural killer cell activity would also be helpful. Oral anticoagulants instead of enoxaparin would also be nice. I don't know if you saw the recent New England Journal article about milvexian, which is an oral Lovenox equivalent, and then broader recognition of immunological factors in RPL and RIF. So I'd just like to acknowledge the many people who've worked with us over the years. The late Dr. Jerry Trobaugh, who really kept the home fires burning after Dr. Beer left us. Melissa Fessler, my nurse practitioner, and the nurses at the Beer Center. Jane Reed, our clinical research associate, and Dr. Winger, who was involved with the lab for a number of years. The ReproSource group, Benjamin Leader and Charles Jenkins, and then the reproductive immunology support group of about 68,000 people who were involved in the program. I'd also like to give a shout out to David Clark and Dobry Kiprov, who got me interested in this area, and then the various practitioners who have referred patients to us. We are deeply grateful for your support. So in closing, I'd like to list the references for the different parts of the protocol shown on this slide and the next slide. And then there are also references from our group, publications from our group about recurrent pregnancy failure. And thank you very much for your attention.